We'll have a live transmission coming up from Sanjay Gandhi Postgraduate Institute of Medical Sciences, where Dr. Goyal is ready with his case.
Okay. Hello. Can you hear me? Hello.
You can. I think you.
I can't hear.
Hello, Dr. Goyal. Dr. Goyal.
Hello.
Yeah, we are able to hear you. I am Dr. Srinivas Kumar here. Can you? Are you able to hear me?
You. Okay.
Dr. Goyal.
Yeah, I am able to hear you.
Yeah,
okay.
we are able to hear you and see you well. I think we
have. Yeah, I can hear you. So.
Yeah, we have Dr. Upendra Kaul, okay. Dr. Krishna Reddy, Dr. Ajay, and Saurabh.
So I'll just.
We request Dr. Trupti Deb and Dr. Sunil Kumar also to join on the stage from the Indian side. Please come on to the stage. I think Dr. Kaul to conduct.
Okay. Okay.
One thing very
good
dear
morning,
is,
so I'll just should I start? Can you? Okay, fine. So good morning. So we are here transmitting a case from Lucknow today, and I am indeed it's a pleasure to be with you today. All right. So the case that I have, I think I'll just introduce you to with me. Can you come closer?
Yes.
With me is Rupali. She is just joined as faculty in our group.
Hello,
so Rupali is there, and then we have Shivdayal at the back, who is the nursing in charge, and then we have our residents here. So
Dr. Goyal, can you hear us?
I'll ask Rupali to. Can you just show the slides, please, for the case? Yeah, I can hear you. Can you hear me?
Yeah, we can hear you, but can you hear us? This is Dr. Kaul.
Yeah, I can hear you. I can hear you.
Oh, good.
Yeah, good morning, sir. Okay, can we have the slides for the case, please? Okay, Rupali.
Yes, sir. Good morning, everyone. We are showing a case of 48-year-old male. He is a chronic smoker with no non-diabetic and non-hypertensive. He presented with stable angina class 2 for past 3 months, and he had a rest pain on 3rd of August this month, and which showed non-STMI ECG was showing T inversions in lead V2 to V5, and troponin I was elevated. It was 10.2 nanogram per ml, but his echo was LV normal size, and there was no renal wall motion abnormality. This is the ECG of the patient, which showing the same findings, T inversions in the V2 to V5. So we did his angiography, which we will show you.
Can we have the angiogram now? So what the angiogram showed was that the right system is normal. Can you just go on? So it's a reasonably big right system, which is normal, and next to the left, and okay, that's the diagnostic angiogram. So what the left shows, there is a suspicion of a critical stenosis in the mid-LAD just beyond a big diagonal, and the circumflex system shows occlusion. If we see the other views, can we see the other views, please? So you can see the circumflex is occluded, but distally doesn't look that big. Next, onwards. The LED disease is not well profiled here. Next. And next please. That's aleocaudal. Go on. There's some lucency in the LED at the point where diagonal is coming, and that's where you see that there is a critical LED. So, so the LED is critical just beyond the diagonal, and there is moderate narrowing before that where the big septal is coming.
Okay.
So with that background, you know, the patient basically has two diseases, one in the LED which is critical, and a circumflex system small which is occluded. So I was just wondering, I can ask the panel as to what do they think, what should be done first? Which vessel should be handled first? If you want to give an opinion, then I'll tell you what we plan to do. Can you hear me, please?
Yes, we can hear you. The question is what?
Am I
Whether
audible?
we should handle the circumflex or the LED first, or what?
Or the LED, yes, yes.
Can you show the ventriculogram again?
So if you can, the ventriculogram is normal, I can tell you. The ejection fraction is 50% plus, so that's the ventriculogram.
Yeah, the LV is normal.
I don't think
It doesn't show any wall motion, although troponin is high, and the ECG shows
Can you make
deep T inversions in the chest leads.
And you didn't do an LAO
So
ventriculogram?
what do you think is the... No, we didn't. But on the echo, we know the ventriculogram is nearly normal, as we see on the angio also.
Can you go back to the caudal shots of showing that
Let's
circumflex?
have a look at the
if there are any
angio
thoughts
again.
you could convey,
Let's have a look at the
go back, please.
ariocaudal or something which shows circumflex also. But
No,
yeah.
right, nahi,
Right
left
is
system.
normal.
Right is normal. Right is normal. Left system.
nothing.
Yeah, left system. Show the last LAO of the left. Last LAO. Last injection. Of
Yeah,
the
that's
left.
actually-
This one is okay.
Yeah, that was a good one, though.
But nothing.
So that's the epicaudal showing the circumflex.
Which does not,
And can
it
we
does
see
not
the
appear to be
areocranial?
small.
Last one.
I mean, it's got a bifurcating OM down there, and it's subtotally occluded.
Yeah, but the LED is reasonably big. It's
Yeah.
very big, and it's a bifurcation disease, and with a critical at that point, and especially with the type of ECG change that is there, I would still feel that maybe the LED is the culprit. And so the plan is to do the LED actually before me first,
Yeah.
and then we'll do the circumflex.
Yeah, I'd agree
Okay?
because the area at risk
Because,
is the largest with the LED.
there are some issues,
Circumflex is
trying
small.
to chase.
It is, not totally occluded. It is,
Yes,
distal
and
vessel
there is
is
a
being
big diagonal
filled.
that is coming
Right
there.
is normal.
I mean, it's also possible that there's two
Yeah.
culprits. I mean, he could clearly
Yeah.
have more than one
So right
thing.
is normal, taking care of part of the circumflex territory. So what I would think is we should probably handle the LED system, because maybe the circumflex is also a recent one and it would just go through, no problem. But if it is a chronic occlusion, there is no point chasing a small vessel occlusion with a big LED sitting there with a critical disease. So
Yeah,
with
no,
that,
I agree
so
with
we
that.
have just put the wires in.
But I don't know why you keep
So-
calling it a small occlusion, because it's
Yeah. So
it's
can I
not
have the balloon,
small.
please?
It's smaller than the LED, but it's a reasonable sized territory for a young person with a normal ventricle.
Yeah, it's not, I agree it's not small, but in this setting it's a little difficult choice, but going by the patient's history, going by the ECG change, by the anatomy, I still thought that I debated on it, then I finally decided I think I should do the LED system first.
No, I think the EKG,
And
it makes sense.
so the wires are in, and
Dr. Goyal, the diagonal is as
Yeah,
big
because
as,
we
if
see
not
in
bigger than the
fact,
LED itself. So what's your strategy for the diagonal? What have you planned for the diagonal here? I think that's the most important thing as far as we agree that
Yeah.
the LED should be done first, but the
Yeah,
diagonal is really
that's
very big.
correct.
So what's your strategy? What's going through your mind as you wire both the diagonal as
So
well
we
as
have
the
two
LED?
wires.
Yeah.
Yeah. So, yeah, I have wired both the vessels, and the strategy here, if you see that the mouth of diagonal is open, at least in the diagnostic as of now. So with the mouth of diagonal open, I would go for a provisional stent. I would plan for a provisional stent. I would stent the LAD and well, maybe balloon dilate the diagonal and then open the struts of the stent towards the diagonal and then see for the result. Angio, please.
Can you comment just a second on the equipment? It looks like you're using a 7 French system and from the radial. So did you upsize the sheath, or is this a sheathless technique?
Yes, that's right. That's correct. Actually, what we do, can we show the slide, the next slide, please? Can you show this Doppler? Okay. So what I usually do when I am doing complex bifurcations, you know, your life is much more comfortable with a 7 French system, and I am committed to a radial technique. I usually do radial all the way through. So I look for the size of the radial artery on ultrasound, and if it is more than 2.3 mm, you can put a 7 French system easily. And this artery incidentally was 2.8, and majority are bigger than 2.2, 2.3, and you are able to put a 7 French in those cases where there is, because the other thing is I had a plan of putting a BVS in this, and we all know BVS is a big French, means it's a big caliber. So if you have to put a BVS along with a balloon, sometimes you may find it difficult to track both the things through a 6 French system. And that is why I electively chose for a 7 French, having seen the size of the radial. Is that okay?
Oh, you'll need a 7 French anyhow, because at the end you'll have to do a kissing and all that. I'm sure you'll need a 7 French anyhow.
No, I mean, I think it makes a lot of sense. The thing too is
well, kissing you can do. Although I don't think I would advocate a crush stent on a BVS, but you know, you should have all your options open. You can do kissing 3.5 and 3 and 2.5 through a 6 French system, no problem. But diagonal. I need it on 2.5. 2.5.
No, I think the other thing too is that even if the diameter of the radial artery is not that big, you can also use a 7 French sheathless, which is basically a 5 French hole, and that would also give you similar setting. The only thing is that the support is not the same.
Well, incidentally, we don't have the sheathless with us right now.
Yeah, we don't have it either. Actually, what I typically do is you take a multi-purpose or some other catheter through, and you just take a regular 7 French guide and just insert it without the sheath. And it actually, the only problem with that is the transition point where it enters the skin can sometimes be difficult, but in general it works pretty well. And you can even use the balloon-assisted tracking technique to get it in the arteriotomy as well.
And also many of us who use ETO balloons, if you have to put in 2 ETO balloons through a 6 French, it is difficult.
So that's the diagonal going up.
Yes.
So would everybody here have dilated the diagonal? Would you have dilated the diagonal first or no? It didn't look that diseased.
It looks all right. I mean, you only said, Dr. Goel, that the diagonal mouth is open and it's quite widely patent. So, I mean, what Dr. Kirtani means is why did you dilate the diagonal?
At the mouth, on the LAD side, well, I often do that to make, you know, sometimes the diagonal mouth is open, but the LAD just at the point where the diagonal is coming because I did LAD twice with 3.0, but still the proximal part was not coming back, was not showing well.
Yeah.
Angio, please.
That's fair. I think that's
so, you know, it is, so that was the reason. So because there is some mess up, something complex there. Can I have a 3-0 again on the LED, please?
Yeah, Ajay, I won't have dilated the
just
diagonal
make
first.
things
I'm
fit
not
all
one of
right.
the proponents of dilating the diagonal if it doesn't look diseased at the osteum significantly, because you dilate it, you can produce problem there, and then you are bound to do something on it.
I also did not want to do that, but
Yeah, my approach in these is to, if there is not significant disease in the ostium of the side vessel, just leave it alone. And sometimes if I need, I'll use an IVUS as a tiebreaker. Because it seems big enough that you should be able to go back and rescue it fairly easily if need be.
Maybe a drug-eluting balloon at the diagonal ostium would have been
Can I have a grip
better
balloon?
option.
Grip balloon है क्या यहाँ पे? हाँ, अभी कर रहे हैं.
So what size balloon is that?
Slip कर रहा है actually the balloon. Grip ले आओ.
This is 3.0?
What size balloon is that, Dr. Goel?
Actually this
3.
that was a 3-0 balloon, but now so the balloon is actually slipping, so so what I usually do for that, give me a grip balloon. Can you show this please? This is what is a grip balloon from Acrostack. It has tiny knobs on its surface, and I am sure with that it will not slip, because sometimes if the lesion has a little more fibrotic element, the balloon slips. अच्छा देखो अभी कर रहे हैं, जब रुके नहीं, मिडाजोलैम दे दो, मिडाजोलैम.
The other strategies for that is use a slightly longer balloon or go up on the inflation device a little more slowly.
मिडाजोलैम प्लीज. हाँ अभी कर रहे हैं. Yeah, you see now it has caught it. It has not slipped. This is a grip balloon.
That's very nice. Yeah, I've never used a gripping balloon. I don't think it's available in the U.S. But it seems like a good idea.
अभी कम हो जाएगा, हैं? देखो इसको इसमें से अलग करो. देखो भैया थोड़ा सा तुम्हें वो करना पड़ेगा तभी कम होगा. अभी करीब 10 मिनट लगेगा बस. ओके. एक मिनट.
ये पकड़ो.
कम ऑन एंजो. हाँ या देखें एक बार. रुक जाओ.
हुकिंग सेटिंग.
रुके रहेंगे. Come on, just hold on. Come on, inject.
There's a small dissection there, looks like, probably.
I think I'll put a stent there. Okay? Yeah, I think I'll put a stent that will sort it out. Okay? So we can have a absorb stent. A 328 would be okay. 328. Now. Can you give me that?
I think you're going to require 2 of them.
No. No. So it's a 320. I think 28 might work. Let's see. I have a feeling 28 might work. I am taking a 3-0 because the distal vessel actually is smaller. So we size it by the distal vessel. Although the proximal looks big, maybe I'll have to do some pot for the proximal.
You're going to go up to that septal or short before that, or what? I mean, what's the distal landmark for you to go up to the for the stent?
Yeah, I think I'll
because
go
the septal,
till the septal.
The area around that septal also looks like
I think I'll go till that septal.
And maybe we can have a little bit of a comment from other panelists. If because of the size mismatch here, the sizing of the BVS is an important issue, because if you size it distally, it'll be adequately sized, but the proximal maybe not. But if you size it proximally, it may be too big distally. So how do you work through that?
That looks all right. Huh?
Yes.
Are you planning to use any imaging modality here, IVUS or OCT or something? Because that will be important when if you're going to put a BVS, I would.
Yeah, I think I'll do OCT. I'll do OCT. Yeah. For BVS, I think imaging is important.
Yeah, that's right.
I plan to do the OCT. Okay.
Hey, sir, guiding and all that.
Absorb, as you know, comes in only 3 lengths: 12, 18, and 28. 2.5, 3, and 3.5.
But so, do you think that proximally, 3.0,
proximally,
the
3.0
size,
it looks at least 3.5, maybe more.
So by putting a 3.0 in there, can you post-dilate it to 3.5?
That's right. Because,
you can't, that's what I'm saying.
If we had the OCT beforehand, we could have, measured the length also, and then possibly 3 distally and 3.5 proximally, because we know the limitation of expanding absorb.
Right.
So we go up slowly.
Or maybe you choose 2 of
Yeah.
So you go up slowly, 14, and I think up to 16. हाँ, थोड़ा दर्द होगा. अभी कम हो जाएगा.
Okay. Now, when you're doing a bifurcation, we normally with a metallic DES would jail the wire and have no issues with it. If there's resistance pulling the wire, do you have to do it more carefully, or it's generally okay?
Yeah, we've seen that it really doesn't make much difference,
Yeah, my personal approach is to do exactly that and then pull out the wire before post-dilating it.
Yeah, that's usually, but you wonder if can you disrupt the stents by, by doing that. So the OCT will be helpful to make sure that there's no issues at the end there.
Actually, the final dilatation we like to do after pulling out the wire and not go very high on the pressures, what we call as the hugging balloon, not going very, very high on pressures.
Can we just center that, please? Yeah, thank you.
Back break.
Come on. Inject. Okay, so distal looks a little.
So that's probably the stent length is slightly short of the distal. That's
yeah, we were debating on the panel where distally, if you needed to be about 4 or 5, 6 millimeters more distal.
Yeah. Can I have some nitro, please? Nitro. Is that okay? देख के और सक करो.
Dr. Goel, what are your thoughts about IVUS here to look at the distal vessel and the proximal sizing?
You're going to use the OCT anyway. So.
Yeah. I think I'll use the OCT.
This is diagonal, sir.
This is diagonal. Okay. Can I do an angio now?
Yes, sir. Fill.
Inject. Well, distal is not bad. Can you see that?
Yeah,
I think we'll do an OCT and see what it looks like.
Some adjunct imaging would help.
We'll do an OCT and see.
And the good thing is diagonal remains widely patent without any pinching at its origin, and also I don't think you need to do much for the diagonal here.
Yeah. So that's the OCT catheter I'm trying to put in. Can you connect it?
Yes, sir, connecting, sir.
Right at the bifurcation, it looks perhaps a little underexpanded, but I think the OCT will demonstrate clearly what's going on.
Ho gaya? Okay. So we have just connected the catheter. Someone should OCT screen. How will you show? हाँ बस ठीक है भाई टांग सीधी रखो
नहीं वो नहीं दिखा रहा सर एक सेकंड नो सर वेट
एक मिनट इसको पकड़ो एक सेकंड जस्ट होल्ड ऑन अनलोड कर दे छोड़ टांग सीधी कराओ ना इसकी भैया जरा टांग सीधी रखो यार तुम ऐसे तो नहीं होगा काम ओके
यस सर
अभी चलने दो जाओ आ जाए क्या है Is there a problem? No, you did not check it before?
It was checked, sir.
Just a sec. Just a sec. There is some. Huh? Okay. नहीं तो या तो देयर इज अ प्रॉब्लम इन दी
कनेक्टर अभी लाइव में दिखाया था इट वाज शोइंग सर
No, so there is some problem in the actually OCT connector. That's the problem.
Okay, while we are waiting for Dr. Goel to finish, let's
so
ask the audience.
Can I see IVAS then?
Let's ask the audience. How many would you have used
you
a
see
BVS
there is some
here?
problem in the OCT
How many of the audience would have
know?
used a BVS as opposed to a routine drug-eluting stent? BVS comes in very fixed sizes, as Dr. Kaul said. So, I mean, what's your choice? Do you think BVS is a good choice here, or do we go back to a something like a Science Prime or something?
Give me a wire.
Audience, still alive.
Give me another wire. Give me that BMW or Elite wire. Okay, wire introducer. Wire introducer. I need a new 1.5 balloon.
Are you planning to IVAS now, Dr.?
Yeah, Shashikant, yeah.
Actually, there was some problem in the IVAS, in this OCT, connecting module, because we have a new catheter, but it is
the size of the lesion, so I thought and decide exactly what is the length and how much should be used, which kind of size of the stent. Probably 2 stents would have been better, one 3.5 proximal and one 3.
I'm just, because there is some tiny lucency in the diagonal mouth.
Yeah, I mean, I think for the audience, if you're planning on doing the OCT at the end, then it's worth doing the OCT at the beginning so that you can plan the case accordingly.
ये इसको ऊपर आने दो ये इसको ऊपर क्यों नहीं आने दे रहे हो टेबल को ऊपर आने दो
One question. Suppose this diagonal was severely compromised and you have a limiting flow, limiting flap there.
Before the angioplasty or after?
No, after the BVS.
After, okay.
So what would be your strategy at that time? If the BVS is already deployed and you have done a plain balloon at the diagonal ostium, you have a flap there, there's significant plaque shift, the diagonal is closed. What would be the options after implanting at BVS?
वो LED है.
What's the question?
If after the BVS the diagonal is compromised, what would be the option?
You wire it and dilate it. And you have to restore flow.
Give me a 1.5 balloon, please.
If the diagonal is compromised, then there's no other option except to wire. The wire is already there. You have to put a balloon and maybe put a stent if necessary. But BVS is not a very good thing to rewire and recross and open up and all. It's not a very good I mean,
how much would you distort the stent?
That's what I'm saying. I mean, PVS, that's what I'm asking you. How many of you would have just gone for a routine stent rather than a BVS here?
So
seeing that the diagonal is so big, if at all it gets compromised, then repairing it would lead to a lot of problems.
You see, as far as dilating the side branch is concerned, you can open the side holes of the BVS, there is no problem, to a maximum of 2.5. And that is what I am just trying to do, because there is some tiny little lucency which I can see at the mouth of the diagonal. And for that I usually do it graded. You first do it with 1.5 and then go higher if at all you want to go. So I'll first do it with 1.5.
Dr. Goel,
I'm just trying to open the strut, that's it. And this 1.5 is not going to distort it.
Dr. Goel, concern from the audience is that if you distort a BVS, is that a good idea? How much can you distort a BVS? I mean, we don't know much about the BVS and all. How much can you distort a BVS by putting in a balloon and all that?
Yeah,
I mean, you can tell us. I mean, we don't know. We are asking
but you can always. People have been doing it in bifurcations.
In BVS.
No, because I have had experience for my own this thing. You can dilate it. Yeah, you can dilate it till about 2.5 maximum.
A BVS.
And you shouldn't be doing it more than that. And yes, the side branch you can open till 2.5 maximum. And when you put a kissing balloon, it should be more of a snugging balloon rather than a kissing balloon, because you should not have two balloons inside the proximal part of the vessel, otherwise it will blow it up much more, which is not right. Okay? So
what if diagonal gets completely pinched? What is your strategy in that case?
And can I have a 2.5 now? 2.5. Come on, yes. Give me 2.5.
No, that's exactly what we are discussing.
If plain balloon doesn't work, are you going to put one more BVS or a routine stent in that diagonal?
Okay. Yeah, you can put one more BVS, although one doesn't have too much of data on that. But what?
No, I'll put a BVS only.
There's no problem.
In case I need it, I'll put a BVS only.
With those, platinum markers which it has,
you can do that.
Place it properly.
Yeah, why routinely dilate the diagonal here? Why not just IVUS and polish off the main vessel and then see if you need to do anything to the side branch?
I need a 3.5 balloon now.
So NC?
In the LED.
NC, sir.
NC.
NC.
3.5 NC in the LED.
He has 10 minutes more.
So you're gonna take a 3.5 NC in the proximal segment?
Dr. Goel, keep it in mind that you have 10 minutes more, although we have extended it by 5 minutes.
Yeah, in the proximal segment. Yeah. Okay. Okay. Can I have 3.5 NC? 3.5 12 quantum? Yeah.
So any concerns about putting a 3.5 NC in the 3.0 BVS? Professor Kaul? I mean, I think it's typically not advised, correct?
Yeah. I mean, you're putting a 3.5 NC in a 3 BVS. Is that an advisable thing, Dr. Goel?
Yes, you can. Yeah, that's correct, because you can expand a 3.0 BVS to a maximum of 0.5 more.
Yeah, you can upsize
maximum 0.5. To 0.5 more, and here when I do 3.5, I will not go above. The rated pressure of 16. No. You get my point?
Right.
So that is the precaution that you need to take, and this I am going to do in the proximal part of the stent, because the proximal vessel is bigger. Test, please.
So probably in this case, because the gross discrepancy in the proximal LED and the segment which is stented, I think an IVUS should have been done before the procedure to know whether you should prefer a BVS or
yeah, actually I was planning the OCT, but somehow it is not working, so I have to make a shortcut. The OCT is there, but there is some problem that is not connecting. So that is the reason that I have to, otherwise I would have certainly done an OCT on this.
If we can go back to
before doing this 3.5.
If we can go back to the diagonal for a second, that's an angiographic artifact. That little line across the ostium diagonal is always an angiographic artifact. It's caused by a strut being in the way of the contrast. And I would not chase it. Because the only thing you're going to do is distort the main stent.
I think that...
Hat, sister.
So the stent is already... So it's already distorted.
Come on, inject. So, actually, angiographically, it doesn't look bad at all. But...
Dr. Goel, did you listen to the comments of Dr. Gary Mills?
Can I see this view? Yeah.
No, he's agreeable to that.
I agree. You see, this could be what is called a Mach effect. This is because of the sharp edge of the stent on the LED that you get what is called a Mach effect. And I have seen it in the other view. That is why I saw it in the other view, eleocranial. Can you show the previous one? And it doesn't come, it's not seen there. Stop it there, please. So I agree, and but sometimes it may be real, but here you see that thing, run it, keep running it. So the diagonal looks reasonably well open, and I have made the strut open by 2.5 millimeter, and then I have dilated it with a 3.5 across the point where the strut was expanded, so as to straighten out the whatever distortion would have been there. Do you agree on that?
Yeah, I mean, I think the result
and the
is
distal
quite
vessel
okay.
looks good.
No, we agree. I mean, I think the whole question is from the beginning whether you needed to dilate the diagonal to start off with, and it may have ended up like this.
I should have. Come on.
I think the only point that now remains is what are you going to do with the lesion after the stent? Do you think there's something after the stent? Are you going to chase that or leave it alone? I mean, otherwise your case is finished.
I don't really think so. Can you freeze it? Can you? Because you know it was some part was spasm, if I'm not wrong. Can you? This looks reasonable, very good. In fact, you see there is nothing beyond the stent end. It's perfectly no. So immediately when you put the stent, there was some spasm element which has now gone off.
Yeah, I think that's quite a good result.
And the diagonal is also well open, and that is the standard strategy I do for BVS, to open the strut and then do the proximal optimization. I would certainly do it with OCT. Please bear with me. I have it here, but somehow there is some problem that the OCT machine is not showing itself connected. So that's the problem. I don't know what has happened there.
The diagonal wire is still there, just to remind you.
Well, it looks like a great result, and I think while you can OCT it later, I think we're gonna depart at this point because we have to move on to the next part.
Yeah, I'll try to fix up what's wrong in the OCT because I don't know what's gone wrong.
When are you going to remove the diagonal wire, Dr. Goel?
And then I'll in the same sitting I will now try to do the circumflex if it is okay.
Yeah. No, I would just probe it with the soft wire and see, and if it's a CTO, then you can leave it alone for now. Oh, thank you very much. Great job.
Hopefully it should, because I'm not going to chase it like a CTO. If it goes with a soft wire, it's fine.
Right, exactly.
Good.
Great job.
Thank you, Dr. Goel.
Thank you, Dr. Goel. Thank you very much.
Okay.